Well, good morning, everyone. I hope you'll hear me well. My name is Carlos Cáceres, and on behalf of NEMUS, I welcome you to our 8th webinar this week of this World AIDS Week. You may know that yesterday we celebrated World AIDS Day, and today we have the pleasure of having here Dr. Jared Baeten. Jared is an associate professor in the Department of Global Health and Medicine and an adjunct associate professor in the Department of Epidemiology at the University of Washington. Uh, his main research focus is on the epidemiologic and biologic risk factors for HIV and other STIs and clinical trials of novel interventions for prevention of HIV-1 transmission. He co-chaired the Partners PrEP study. You know that it was a randomized trial with among 4,700 uninfected heterosexual men and women in Kenya and Uganda that demonstrated the efficacy of pre-exposure prophylaxis. And together with that study, or after that study, there are some other connected studies. For example, this large observational study of PrEP adherence, and also some ancillary analysis on innate and adaptive immune responses related to PrEP use. So Jared was, gave an excellent plenary presentation at the recent Research for Prevention conference in Cape Town, South Africa, and he has been extremely kind to accept, sort of present sort of a more informal, commented version of that presentation here with us today, and we really are very pleased to have Jared with us this morning. So, Jared, welcome. Welcome to, here. Before actually, I wanted to say a couple of things. The session will be recorded. We'll eventually, as soon as we have it ready, we'll provide a link through our listserv, and it will be accessible on our website. We also wanted to mention that our session in Melbourne, the webcast of our PrEP session in Melbourne was already uploaded in our website as well, so you may access it whenever you want. And in terms of this webinar today, Jared will speak for the time he considers appropriate. To improve sound, we'll mute others, and we'll have the chat window to make questions or comments. So after his talk, we can dedicate some time to questions and comments. That's the dynamic planned for us today, this morning. And I wonder, hi Jared, are you there?
Good morning, Carlos. I'm here. Can you hear me?
Yeah, absolutely. Thank you very much again for being here with us. And the floor is yours. Please go ahead.
Great. And can you confirm that you can see the slides now?
Yes.
Okay.
At least I can do it.
Great. Okay. Hi, everybody. It's great to be here. Carlos and everyone at NEMUS, thank you for asking me to give this talk, and especially in this World AIDS Day week. As Carlos mentioned, this is based on a talk that I gave in Cape Town at the Research for Prevention meeting, and I think I would give a call out to that meeting, not to watch this talk again, but to watch a whole bunch of other things that are available online. Virtually the entire meeting appears to be webcast, and it for those who weren't able to attend, or even for those who were able to attend, because there were so many great concurrent things. I've been watching several sessions since that meeting ended at the end of October online, and I would encourage others to as well. So Carlos asked me to replay this the talk from Cape Town, so most of the slides will be the same, although some have been adapted. And I think what I would I see all of your names who are on here, and I know that many of you were there in Cape Town, and some of you were not. But if I use the chat box if you want as we go along, and I'm happy to try to read as I talk. So in Cape Town and here I was asked to talk about advances in antiretroviral-based prevention, both treatment and PrEP. So we'll go from there. My second slide is disclosures, for which I do not have financial relationships of my own. So the theme here on this third slide is with antiretroviral-based prevention and tremendous advances in the last 3 years, we have seen both great optimism and also great confusion about what we should do and what we should do next. And I think one thing that we are all seeing in this last several months has been changing of how we talk about prevention, changing how prevention is being viewed in really positive ways. And I think a goal of my talk, this talk today, my talk in Cape Town, and how I've been talking to other people about prevention and thinking about my own new research and implementation work, is how we rethink and re-evolve and change our ideas about the science of antiretroviral-based prevention. So my goal here was to modify and change our ideas as this science continues to advance, and motivated by this quote here. So here are the 5 ideas that I've argued are really important in how we've been thinking about antiretroviral-based prevention, or how we should rethink and change our ideas about antiretroviral-based prevention. And we have learned now, and this is worth great discussion. This has taken great discussion and has taken great pains to get here, that we recognize that when taken, antiretrovirals work for prevention, both as treatment and as PrEP. The second is, I think for both treatment and PrEP, for treatment we have known for a long time that you don't have to be absolutely perfect. And I think we as those who prescribe perhaps expected people to be too perfect long ago, and now we recognize that people can be people and still benefit greatly from treatment. I think for treatment's benefits, treatment for prevention has much of the same advantages as treatment for treatment in terms of its ability to be forgiving to imperfection. And I think we recognize now that PrEP as well, you don't have to be perfect to be good enough. And we'll talk more about that. As PrEP has rolled out, and as treatment for prevention has had greater discussion and greater rollout, of course, we have come to recognize there are barriers, and barriers to both, and both treatment and PrEP for prevention. And the expectation that those barriers don't exist is naive, because those barriers are real. And honestly, sometimes they're us, all of us, those of us who write prescriptions, those of us who talk about prevention, both locally and globally. And perhaps we don't need to stand in the way quite so much anymore. I emphasize that PrEP is wanted, but it is also not forever, not for everyone, and not one size fits all. And the idea that PrEP is being developed in multiple strategies motivates this. And then finally, that there are risks in doing, but the greater risk is in not doing enough. So I framed the talk around these 5 topics, and I'll go through them each individually. So when taken, they work. These are the data, the top in blue for ART, and then the remaining in the lighter color blue below, the 5 studies that demonstrated that PrEP is efficacious for HIV prevention. And these are, of course, the randomized trials, with efficacy ranging from 39% in the Caprisa 004 PrEP trial of tenofovir gel to 96% in the HP10 052 trial of antiretroviral treatment for HIV prevention, with a range of efficacies in between for the remainder of the PrEP studies. When you line these up, especially these PrEP studies, we recognize that PrEP trials come against this very clear line relating protection effectiveness across the x-axis to percentage of individuals in the study who were adherent. And as you see, in the studies where the majority of subjects, beginning with iPrEx and moving up to the right from there, were adherent, they demonstrate HIV protection, with the protection estimates higher when more of the population was adherent, and the proportion of individuals who were adherent directly proportional to the degree of HIV protection seen. And I think, as we'll see later, this is likely as a result of the fact that PrEP, when taken very well, appears to be quite protective against HIV, so, which is why this lines up so nicely against a directly proportional line. There were two trials, of course, of PrEP where were less than a majority. In fact, much greater, less than a majority, were not adherent to PrEP. And these trials, FemPrEP and VOICE, did not demonstrate HIV protection. Indeed, they could not demonstrate HIV protection because the PrEP-exposed population, in the end, was not really exposed to PrEP at all. The HP-1052 study achieved very high adherence and falls at the top of this line because the proportion of individuals who were adherent was very high, and thus the proportion who achieved HIV protection was also very high because ART, like PrEP, when taken very well, appears to be extraordinarily protective against HIV. Although we know that in real-world settings, where antiretroviral treatment is monitored less aggressively and less intently than it was in HP-1052, that real-world effectiveness of antiretroviral therapy here in the middle is lesser. About 75% of individuals are estimated to be well adherent, achieving viral suppression by UNAIDS estimates. And in the meta-analysis of observational studies of treatment as prevention, effectiveness is estimated to be about 64%. Across multiple observational studies, and then in contrast to HP-1052, reflecting the difference between real-world effectiveness and optimized, well-monitored clinical trial like HP-1052. For PrEP, we know, as I mentioned before, that when taken, PrEP appears to be extraordinarily protective against HIV. And these are data from Partners PrEP and iPrEx-OLE and iPrEx itself, associating the detection of tenofovir in blood samples with degree of HIV protection, including estimates from iPrEx and iPrEx-OLE, suggesting that at dosing of 4 to 7 times per week for that study population, the degree of HIV protection could be as high as 100%. So that we can see that PrEP is extraordinarily protective when taken. Emphasizing that when taken well, for HP-1052, where adherence was nearly universal in the study population because of the ability to monitor viral suppression in real time and intervene, and then in the PrEP studies with detection of tenofovir in blood samples and detection of sufficient tenofovir in blood samples, protection against HIV for both of these interventions exceeds 90% and arguably potentially approaches 100%. So that's great. We've also learned that well enough doesn't always have to be perfect, that you don't always have to be perfect to be good enough. In the iPrEx-OLE study published this past summer around the time of the International AIDS meeting, there was intensive analyses done to associate the detection of tenofovir and specifically the quantity of tenofovir in blood samples with the degree of HIV protection. And what was seen was that 100% protection against HIV was seen in that study population of heterosexual men and transgender women who had concentrations of tenofovir in their blood that would be associated with taking at least 4 tablets per week, suggesting that consistent PrEP taking, even when not necessarily perfect, can be highly protective. And I think this emphasizes that for a medication prescribed daily, it is often any medication prescribed daily, whether for hypertension, for diabetes, for HIV prevention, for mental health, or even a multivitamin, our ability to take it every day sometimes falls short. But if that falls short to only 1 or 2 or maybe 3 times per week, we still may be getting great benefits from this intervention. In fact, perhaps this is a particularly forgiving intervention, maybe even more forgiving than other medications that we take for other health conditions. Let's look at what adherence looks like in these studies of PrEP. This is data from our own Partners PrEP study. This is individuals is longitudinal analysis of tenofovir detection in blood samples from persons who were taking PrEP, split into those who had PrEP detected at their very first monthly visit, 1 month after randomization, in blue at the top, and those who had PrEP not detected at their very first month after randomization into the clinical trial and then continued thereafter. What you can see here is that those individuals who were taking PrEP from at the very beginning generally stuck with it. They made a decision very early on that taking this pill was an acceptable intervention for them, and they generally continued to do so. You can see that some people dropped down. Those are either individuals who decided to discontinue or who were discontinued, for the most part individuals who became pregnant in the study because we didn't continue PrEP in women who became pregnant during partners PrEP. Individuals who very early on decided they didn't want to adhere, in orange at the bottom, rarely started adhering. And I think this would be true for any prevention intervention with a daily medication, that individuals might decide relatively early on whether this is for them or not, and may decide very early on not to continue it. You can see that very few of those individuals bumped up thereafter, which I think is a good reminder to all of us that starting something once you've failed once it has failed to capture your attention may be very hard to do. Similar results were seen in iPrEx. Here split into those who were adherent at the beginning and in orange at the top, and those who did not take PrEP from the beginning in green at the bottom. You can see that the proportion of individuals who are green at the bottom is higher in iPrEx, which is consistent with the overall use of PrEP in iPrEx. About 50% of the individuals were taking PrEP. Although you can see how this splits out is that it's generally that 50% of the individuals were consistently taking PrEP, and about 50% of the individuals were consistently not taking PrEP. I think this is consistent with what we know for other health behaviors. I use the dental floss example a lot when I give talks, but also for oral contraceptive pills that people tend to take. The preventative medication like oral contraceptives well, as long as they're taking it, and then when they discontinue it thereafter. We'll talk more about oral contraceptives later, but I think we have a much greater suggestion that PrEP is potentially more forgiving than oral contraceptives for the health condition that it's designed to prevent. So in summary, emerging data show us particularly from the iPrEx team, that PrEP, when prescribed and recommended for daily use, has some forgiveness to real-world taking. Those who take PrEP take it fairly consistently. We also know for ART that the majority who are prescribed ART tend to take it well enough to block the virus, even with the barriers that may mean that they may not take every single pill that they're prescribed. And I think in my own practice here in Seattle, where I prescribe antiretroviral treatment every week, I know that nearly all of my patients are virally suppressed, because these are patients who are well engaged in care. But I also know that very, very, very few of them are 100% pill takers. And so in spite of that, people achieve great clinical benefit and great virologic benefit in terms of transmission risk from taking pills as people take pills. So these pills, both treatment and as PrEP, appear to allow people to be human. We've had breaking information, and this is this information that was presented, that came to light during the R4P meeting, first from the iPrEx group, and then also with regard to PrEP in women at the bottom. The iPrEx study reported, without quantification, preliminary results from their randomized trial of intermittent PrEP versus placebo intermittent PrEP during the R4P meeting. Using PrEP on demand, associated with a sex act. What we don't know yet from iPrEx, and this is my own editorialization, is that we don't know the exact degree of HIV protection provided in that study, because it has not been fully released yet, and the numbers, of course, will be extraordinarily important for us to dissect in detail. We don't know how the degree of protection compares to daily PrEP protection, or at least PrEP as prescribed for daily use, and especially the detailed analyses that we have now from iPrEx and iPrEx-OLE. And most importantly, I think, and this needs to be dissected very well, we need to know how many participants in iPrEx use PrEP often enough to make on-demand dosing in that study essentially equivalent to daily or daily-ish pill taking, as one saw in iPrEx and iPrEx-OLE. We may be seeing something that gets at relatively the same place, that one can be imperfect either by design in an iPrEx sort of way, or by being human in an iPrEx-OLE sort of way, and still be getting 4 to 5 doses in a week for the most part in the highest risk persons, and achieving very high HIV protection as a result. It will take great and good analyses to work that out, and I think we're really looking forward to the investigators who are able to do such analyses to explain this to us. Also at the RFP meeting, there were data presented from a pharmacologic modeling study from the North Carolina group and the FemPrep group, associating the degree of HIV protection in cervical vaginal explant tissue with the degree of tenofovir detected in those samples. This modeling study suggested that PrEP could be less forgiving for women than for men who have sex with men, and this has achieved a lot of attention. I think this needs additional bearing out. I think we know very, very clearly from randomized trials, particularly from Partners PrEP, as well as from the TDF2 study, that PrEP, when prescribed daily and taken well, results in high HIV protection for those who are exposed vaginally, both women who are exposed vaginally, as well as insertive heterosexual men who are not exposed to HIV rectally, but who are exposed vaginally as well through a tissue that is anatomically quite distinct, obviously, from the rectum. What we still don't know is the degree of imperfection that is allowable, although I think we know very clearly that individuals prescribed PrEP within Partners PrEP and TDF2 who took it as well as they could, and certainly didn't take it perfectly because people are people, still achieved extraordinarily high HIV protection. And I think that's what we must continue to emphasize with patients who we do not have full information, in the same way that as much information as we do for MSM and transgender women, like we do for iPrEx. For ART, we know that ART has tremendous benefits in settings where delivery and pill taking are imperfect. These are data from the Africa Center group in rural KwaZulu-Natal that show observationally that as ART rollout has progressed, that HIV incidence within that study population within that catchment population has decreased. And thus and this is in a setting where, of course, we know that delivery is imperfect and adherence is imperfect, because delivery and adherence are imperfect everywhere. So these medications work, but sometimes we have to begin to realize that there are barriers to these. That as much as we talk with tremendous optimism about the benefits of PrEP for HIV prevention and the tremendous benefits of treatment as treatment for HIV prevention, there are barriers in populations who are most in need of these. Sometimes barriers that we have set up ourselves, because sometimes the barriers are us. For ART, we have come to realize very, very clearly that even though we can talk amongst ourselves who work on prevention a lot about its great benefits, that not everyone who's offered ART takes it up instantly. In Soweto, a very good study demonstrated that even those who had CD4 counts under 200 had 20% refusal of immediate ART. Within our Partners PrEP study team, these are in HIV serodiscordant partnerships who were mutually disclosed, had tremendous clinical support, and met tremendous counseling support. 30% of HIV positive partners who became eligible for ART at a CD4 count less than 350 declined for 12 months after reaching a CD4 count of less than 350 because they did not feel ready yet. In HP10052, about 20% of the individuals who were randomized to the delayed arm subsequently delayed ART use when the randomized results were reported, and it was demonstrated that ART both had tremendous clinical and prevention benefits when started earlier. These are individuals who, of course, would have been agreeable to starting ART early at the time they were randomized, and they had been randomized the other direction, and then subsequently they declined initiating ART. So even among a very motivated population. And then, of course, from multiple settings where earlier ART is rolled out, particularly for option B+, we have seen, we have all been seeing initial uptake that is very good, but then lost to follow-up thereafter, suggesting that individuals have multiple reasons for starting ART, but also multiple reasons for not continuing it, because, particularly how it fits into their lives. As CD4 thresholds for ART have risen in B+ and in other strategies, we have seen some evidence already that the uptake is more hesitant at higher CD4 counts. These barriers can include both individual feeling healthy, and structural barriers with clinics telling people you are not ready for ART because of the messaging that we have that has been circulated for many years, that ART is something that one has to become ready for and one has to be sick enough to achieve. We have seen this in community-based testing and linkage to care programs in South Africa and Uganda, and these are data recently that we published in Lancet HIV, showing a difference in ART uptake among those who had CD4 counts under 200 versus between 200 and 350. as well as among serodiscordant couples in Kenya and Uganda with our own partners PrEP study, a difference in ART uptake, with the best uptake among those with CD4 counts under 250, lesser uptake among those who are eligible with 250 to 350, and even lesser uptake with those who had CD4 counts greater than 350. And finally, emerging evidence from Uganda suggesting that adherence, once initiated, may also be lesser for those who start ART at higher CD4 counts. Qualitative work has tried to unpack the reasons for this, and this is work that we did among serodiscordant couples in Kenya. We found in mixed methods work in a survey that 40% of serodiscordant HIV-positive partners within serodiscordant relationships were not willing to start ART, and that in qualitative work, a key theme for the refusal of early ART was because, in their minds, starting ART signaled death. And here's a particularly telling quote from one participant: "Like me, if I am given ARVs, I will think I'm nearing the grave." And I think this stems from many, many years of discussion that ART is for sick people. ART makes sick people well, and often ART prescribers telling patients that you're not sick enough or you're not ready enough for ART yet. And switching that around and saying now that everyone is ready is a major sea change, one that we have not fully messaged, maybe even amongst ourselves yet. For PrEP, I think the same is true. Not everyone who offers PrEP takes it. In clinical trials, factors associated with non-use included younger age, lack of social support, low perception of risk, or not attending appointments, and these should all have been expected as they are factors that predict lower ART adherence as well. In open-label access to PrEP, and in the open-label extensions that followed the clinical trials from Partners PrEP and iPrEx, there was an important fraction of the study population who declined to receive PrEP, either because they were not, for reasons much like those above, that they were not ready, not feeling that they were still at risk of HIV, which may be fully legitimate, or may need additional or alternative HIV prevention strategies. In the San Francisco demonstration project of PrEP that's ongoing, 40% of those who were eligible declined enrollment, citing both PrEP-related things, such as concerns about side effects or not feeling at risk for HIV, but also research-related things, which of course are not related to PrEP, just the time to participate in research studies. Stigma has been called out as a key barrier to PrEP use, and I think this is seen both in research work, but as well as in the blogosphere and many other things on the internet. The many commentaries about the stigmas to PrEP use. Stigma related to antiretrovirals more broadly, and the relationship to HIV more broadly, as well as the stigma about being at risk for HIV or declaring oneself at potential risk of HIV, and stigma that extends not only within individuals and in their communities, but extends into the clinic as well. Because lack of knowledge to and access to PrEP, and importantly, shame and hesitation about asking prescribers for PrEP, have been demonstrated to be important barriers for PrEP use as well. This is one abstract that was presented at the IDSA meeting in October, that among men in Boston who were taking PEP, so had already demonstrated some risk for HIV, the majority said they were interested in PrEP, but a third of them said they would not be able to talk to their physician about it because they were embarrassed to do so. Thus, sometimes, an important point to emphasize is sometimes the barrier to both PrEP and ART is us. For ART is us for years telling people that they're not healthy enough, that they're too healthy to be taking ART, and even our descriptions of early ART suggest that we're doing something before people really need it. And I think we need to change how we speak about treatment for HIV prevention. Similarly, for PrEP, our own judgment about who needs PrEP, about whether PrEP is right for someone or not, and our own judgment and discomfort about talking about sexual risks has limited the prevention benefits. Something that we must break down. Because in the end, for PrEP, it is wanted. I think it's clear that ART is wanted, but I think much question has gone into whether PrEP is wanted, and I think it's emerged very clearly now that PrEP is wanted. But with the caveats that is not forever, not for everyone, and not one size fits all. In real-world rollout of PrEP for HIV prevention, we have seen tremendous use of PrEP, where we've been able to do demonstration studies and see what PrEP use has looked like. This is from the San Francisco demonstration project, where greater than 90% of blood samples had tenofovir detected at concentrations estimated to provide 100% HIV protection. Data that reported at IPAC this past June. In our partners demonstration project, which is an open-label project of PrEP provided as a bridge to ART among serodiscordant couples in Kenya and Uganda, different than the partners PrEP clinical trial population. We have seen PrEP adherence at very high levels, with tenofovir detected in blood samples here at 87%, as high or higher than that had been seen in the clinical trial. And importantly, the demonstration project population is at considerably higher behavior risk than had been seen in the clinical trial population because of the inclusion criteria for the demonstration project to try to select individuals at greatest risk of transmitting HIV. So high-risk persons want PrEP in both San Francisco and in Nairobi. The PROUD study, released just before the R4P meeting, demonstrates that in real-world settings in the United Kingdom that PrEP is desirable. Among MSM who were in that study, delivery of PrEP compared to deferred access to PrEP was so effective in preventing HIV that the deferred arm was discontinued early in October, when only 10% of the planned sample size had been enrolled. It was obvious with only 10% of the planned sample size that PrEP was so efficacious against HIV even when delivered in a real-world, very real-world setting, that there was no point in doing delayed access to PrEP. And the PROUD population had considerable HIV risk, with high rates of STIs, PEP use, and recreational drug use in the year before enrollment, suggesting that a population at high risk of HIV can have real desire to take and use PrEP and get the benefits that it can provide. And I think this has been emphasized that PrEP provides real benefits for persons who may face high risk of HIV. We've seen this in the Partners PrEP study in individuals who had high HIV pressure because of STIs, because of a high plasma viral load in their HIV positive partner, or behavioral risk such as sex without condoms, women who are younger and perhaps had sexual risk associated with that, or who were desiring children, or women who are using DMPA for contraception, which may in itself increase HIV risk. In the iPrEx and the iPrEx OLE study team, there have been good subgroup analyses to assess the relationship to assess PrEP protection in individuals who had high risk because of behavior, because of anal sex with HIV positive or unknown partners, or because of exposures such as syphilis or recreational drug use. And HIV protection estimates for these subgroups were often as higher for the clinical trial population as a whole, because adherence was often greater for higher risk persons. The iPrEx study team has done some wonderful analyses to assess the relationship between numbers needed to treat and population attributable fraction, which are numbers to assess how PrEP could best be rolled out to provide both individual and population benefits. Key subgroups with strong risk factors for HIV, such as new syphilis, drug use, or sex with a known HIV-positive partner, had very low numbers needed to treat, signaling high individual benefit from PrEP. So these are individuals for whom prescribers should realize that PrEP could have immediate and important clinical benefits because they have extraordinarily high risk of contracting HIV in the relatively near future. The largest proportion of HIV infections within the iPrEx study occurred for MSM and transgender women who had receptive anal intercourse without a condom, regardless of the HIV status of their partner. And for the most part, this was HIV with status unknown. And even in this subgroup, the number needed to treat was only 36. What does 36 persons being treated for PrEP to prevent one HIV infection mean for the world? Well, this is what we see for the iPrEx team, that for PrEP for HIV prevention, where the incidence overall was 4% per year and the relative risk reduction overall was 44%, but of course the frequency of HIV infection was much higher in individuals who were at greater risk. The number needed to treat was 62 overall, 36 again among those who practiced unprotected receptive anal intercourse, and less than 15 among those at greatest risk, such as those with syphilis or cocaine use. Well, for other things in HIV prevention, such as statins for primary prevention of cardiovascular disease or stroke, the frequency of the risk is less, 2% per year or less. The relative risk reduction is 31%, and the number needed to treat for a year to prevent one outcome is 250. That's to prevent an MI. It's similarly to prevent. It's similarly for blood pressure protection, blood pressure control to prevent stroke is also about 250. And of course, while the simple comparison does not take into account the cost of the novelty or an infectious agent versus a non-communicable disease, I think we have to recognize that we do a lot of things for HIV prevention as prescribers, for prevention more broadly as prescribers, with numbers needed to treat that are definitely in excess of 15, 36, or even 62, and thus we have a lot of potential benefit to gain with PrEP in populations who are at real risk. For persons who want PrEP, they say it offers decreased anxiety, better communication, better self-efficacy, and increased sexual pleasure and intimacy. And I think I've emphasized in many settings in the last several months how much we've learned from this kind of work, because there is a whole generation of persons out there who have never had sex without some degree of fear. And I think at the same time we recognize that we all make mistakes, and whether this is within our sexual risk-taking or in other ways, we all have our slips sometimes, as this iPrEx lay participant says, when we really don't take, the safest route. And I think for those who are people out there and who are imperfect in some way in our own lives, PrEP, we can recognize in some way how PrEP may offer someone the added degree of protection to keep themselves safer from something that they do not want to acquire. The advocacy for PrEP has really helped. Personal experiences with PrEP have helped. They've been instrumental in spotlighting prevention needs, stigma, and deficiencies in delivery, and still more information is needed to address provider bias and fill financial gaps. And I think we need this especially for women at risk. At the same time, PrEP is not for everyone and not forever. ART is for everyone eventually and forever once initiated. But PrEP offers an option for persons and periods in life when other prevention options are not enough. Women and men with ongoing or time-limited risk or serodiscordant couples before ART is started, or particularly when ART is delayed, as we see in many HIV serodiscordant couples. We should expect PrEP use to stop, and we should think how to evaluate adherence, since adherence is really only important for PrEP when mapped to periods of highest risk. And this requires a really new scientific way of thinking about adherence that I think many of us are trying to do. It's important to also recognize that PrEP will not be one size fits all. The pills are the first, but there are new pipelines out there, including gels for both vaginal and rectal use, vaginal rings, potentially injectables, which are moving through phase 2 right now. And we would be naive to imagine that any one of these will be workable or work for every one person, because what could be wanted and what should be wanted and what is wanted for other things in health are prevention options. So consider for the future a world where there are multiple prevention options available, including pills, injectables. Some people choose to use none or to use other options. And for those who use a prevention option consistently, most use it consistently, some use it less well, and some use it not so well at all, because that's what contraception looks like in countries around the world, from Swaziland to here in the United States. And the analogy to contraception is apt because there are choices, there's imperfect use, but no one would ever, and there are risks, but no one would ever say that contraception is a failure. And the comparison here stands more strongly that what they offer is individual control over protection, and in spite of concerns about sexual behavior and adherence, where perfect use is the ideal, but real people taking real-world use has individual and population benefits. So the last part is to talk about those risks, because there are real risks. There are risks that have been discussed, but the greater risks is, of course, not doing enough. Resistance has been raised. We know there is risk of resistance with antiretroviral treatment use. Antiretroviral treatment resistance accompanies treatment rollout in every setting where it has occurred, although it has been relatively limited in nearly all settings and gets more limited as the medications get more potent and treatment delivery gets better. For PrEP, resistance risk is even smaller. it was limited, very limited within the clinical trials of PrEP. It did not occur in those acquiring HIV during follow-up, for the most part because they had no drug pressure for which to select resistance. It was dwarfed by the number of persons who were protected against HIV, and it is modeled to contribute to very little to HIV resistance risk more broadly, because compared to what ART is already contributing. This is very, very reassuring for PrEP and resistance risk. Behavioral risk compensation gets a lot of discussion, but the evidence argues against it. Little evidence for increased risk behavior following ART initiation, decreased frequency of unprotected sex in iPrEx and partners PrEP, no increased risk taking an open label extension of PrEP trials once PrEP efficacy was known, and indeed, PrEP and ART have their greatest benefits for those who are already taking risk, for those who are already not using condoms, making these strategies risk-reducing, not risk-creating solutions. Because the greater risk is in not doing enough. In my own country, and in other countries where ART has been available for over a decade, well over a decade, we continue to see stable and sometimes even increasing HIV incidence in the era of high ART access. This emphasizes to me that just making more ART available, as we have done in many, many high-income settings, is not enough to reverse endemic HIV. Because there are important gaps in the care cascade, specifically testing and initial linkage to care, that emphasize that the greatest burdens are upstream of ART delivery, particularly for knowledge of status and then from knowledge of status to linkage to care. Important research and policy gaps must be broken down, because we have to accelerate the diffusion of this innovation. Unless we think ahead. There are important scientific advances in the making. Multiple countries are adopting new ART guidelines. There are large studies evaluating the community-level impact of ART at higher CD4 counts at the same time as new ART initiation guidelines are rolling out anyway in settings, which is great to see that happening in parallel. And there are new approaches to hit that upstream part of the HIV care cascade, including attention to testing and linkage to care and initial treatment. For PrEP, there are demonstration projects and beginnings of rollout in multiple settings, but not nearly enough, and not nearly enough in settings where this is most needed, where HIV has its greatest burdens. There are longer-acting and less user-dependent PrEP agents in development, things that are in phase 3, such as dapivir vaginal ring and tenofovir gel, as well as tenofovir rectal gel on demand plus strategies such as vaginal films and spun fibers that are in early stage development, and of course the injectable agents in phase 2, which have great potential to remove a lot of the adherence challenges, but still will not be potentially workable for everyone. And multipurpose technologies, which are in phase 1, may have great appeal to women who are wanting dual protection against HIV in pregnancy. Policy advances are incredibly important, and these are policies from the United States and globally that change the conversation. And these are motivated, as I said before, by advocacy and science in parallel. And I think when I think about PrEP and ART together, and I work on both of these, I emphasize that the greatest impact will come from rolling these together, when these are implemented effectively and synergistically. The data on the bottom, on the left, are from the Kenya HIV Prevention Revolution Roadmap, and emphasize that business as usual, and right at the top, continues stable and slightly increasing HIV incidence over time, while combination prevention, including ART and PrEP, and then combination prevention targeted to microgeographies with the greatest risk in that country, can have tremendous benefits, really reversing what is an endemic HIV situation. But it's not a single intervention alone, and not in any sense. But PrEP and ART and harm reduction for drug users, for people who inject drugs, as well as PMTCT and better testing and behavioral risk reduction and other strategies that will bring this all together. Thus, in summary, the points that I wanted to emphasize is that for antiretroviral-based prevention, these medications work when they're taken, even when they're taken without complete perfection. The barriers are real, and too often still they are all of us, because PrEP and ART are both wanted. For PrEP, it is different than ART, however, in that it is not forever and not for everyone, and choices and options are needed because not one size will necessarily fit all. And in summary, the risks are in doing, but the greater risk is in not doing enough. And I think there I'm at the end, and I will leave this up and thank you and take questions now.
Jared, thank you very much. I think I have heard your talk in Cape Town, and it's evolved, and you've included all the details. It's very interesting, and I think I mean people should look at your at this recording as well, not only look at the webcast from Cape Town. I actually I mean people are free to ask questions through the chat window, or I mean some people, since I mean we have nice guests here. I mean people can also have a couple of minutes to speak if they want. So just let us know. I wanted to start with a couple of questions. I think you touched on those topics briefly. One was the status of research on PrEP among women, and yeah, actually, a couple of studies are going to start probably to look at, well, not only to look at PrEP, but actually at hormones and HIV risk, and obviously there's a relationship. I mean, among women who might use PrEP. And the second question would be about men and penile infectivity through vaginal sex and through anal sex, if there's any data you could mention. Mm-hmm.
Thanks, Carlos. So for the first question, so studies of PrEP in women, I think I'll take this from two perspectives. The first one from the delivery and the implementation perspective. There are now, I'll say this parenthetically, finally, starting some delivery projects to look at PrEP uptake and use among women at risk of HIV. Of course, the Partners Demonstration Project that I talked about is including women in serodiscordant relationships, and that study has been going on for almost a couple years now, and has enrolled 1,000 couples in Kenya and Uganda, many of which have an HIV-negative female partner using PrEP. So we have some understanding of what PrEP uptake and adherence looks like in heterosexual women in serodiscordant partnerships in East Africa. There are demonstration projects now starting in South Africa and in West Africa, and hopefully soon in East Africa for women at high risk of HIV who aren't necessarily in serodiscordant partnerships, particularly for women, for sex workers who may want to use PrEP, and those will give us great information on PrEP uptake and adherence in at-risk populations. There are smaller studies, including one in Kenya and in Cape Town, that are starting to look at adolescents' uptake. But these end up being very, very small studies, and I think what is not being done well or being done at scale enough yet are studies in general populations, especially in populations with very high incidence in general population settings, such as Southern Africa, where to understand whether PrEP would have a preventative effect when delivered at scale, because what uptake would look like and what adherence would look like. And I think for many of us, that's it is a rallying cry to try to understand whether PrEP could be taken, whether PrEP would be taken, and I think it would be taken by a subset of women and taken well enough to prevent HIV. For your second part of that, for the question of the relationship between, I think you mean exogenous hormones like DMPA, Depo-Provera, or oral contraceptives or other things. There are a number of pharmacologic studies being done to understand if there's a detailed pharmacokinetic or pharmacodynamic relationship between exogenous hormones and PrEP, and those are underway. I will point out that within Partners PrEP, we have done analyses to look at whether PrEP interacts with reproductive hormones bidirectionally. So whether PrEP inhibits the pregnancy preventative effects of injectable or implantable contraceptives, as well as whether DMPA interacts with PrEP in a way that undermines HIV prevention efficacy, and we found no adverse relationships. So women who are using DMPA for contraception do not have any adverse pregnancy preventative effects because they're taking a PrEP, so PrEP doesn't somehow undermine their DMPA use. And similarly, PrEP provides great HIV protection for women using DMPA for HIV for contraception. And so that's very reassuring that for women who are making dual prevention choices using two different agents, one for PrEP and one for contraception, that those can work okay together. Then your second question was about penile exposure. This it's very I think this is very interesting. So I think much of the discussion of the pharmacokinetic work related to vaginal concentrations of tenofovir versus rectal concentrations of tenofovir sometimes gets shorthanded to discussions of women and men. And I think that's, for better or for worse, I think that, of course, is workable, but it also diminishes the fact that the studies are really questions of vaginal tissue versus rectal tissue. And for insertive MSM or for heterosexual men, there's very little pharmacokinetic work that's been done to understand how penile protection from PrEP works. I think, not somewhat comically, I'm not sure that very many men are excited about penile biopsies to get at that, to contribute to that science, so maybe that's been limiting. But I think the consequence is that the grouping of men gets thrown in with rectal exposure, which is probably not completely accurate. However, we definitively know from TDF2 and from Partners PrEP that penile insertive men, who were in that case heterosexual exposed vaginally, are protected extraordinarily well by PrEP, and especially extraordinarily well if they take it. So I think there's really, while it would be nice to have additional detailed scientific work from pharmacokinetic studies, is equally fine to have equally fine, if not better, for communicating with public health to know that the randomized clinical trials work very well in men whose primary exposure is penile insertive sex.
Great. Thank you, Jared. I have a question from Julie Patterson, and she asks, Dr. Baeten, how do you think we should be messaging the differences in onboarding of Truvada for PrEP for vaginal versus anal sex? In other words, how should we explain to people the need to have 20 days of medication for protection in vaginal sex versus 7 days of medication for protection in anal sex? It seems to be complicated.
Thanks for that question. It does seem to be complicated. It does seem to be complicated, but on the other hand, I'm not sure it's quite so complicated. I was just having this discussion the other day with some others about trying to figure out exactly where this 20 versus 7 comes from, because I think we were not sure that for example, in the US CDC guidelines, there doesn't seem to be quite as a rock solid distinction for women and for men. I think what I would say in prescribing PrEP to women and for men is that PrEP is not forever. PrEP is not, especially when prescribed for daily use, PrEP is embarking on a several months at least of HIV protection, and so the first few weeks, like we know, the first few weeks of many preventative interventions may not provide benefit. Indeed, I think those of us who think about reproductive health stuff all the time realize that the messaging for initiation of oral contraceptive pills, for example, in Africa, often has a blanket statement that the first month is probably not fully protected at all, and so that nothing will kick in until your second package of pills is initiated. And so I think patients who are receiving PrEP may be very amenable to recognizing that this doesn't kick in for a while. I think our desire to give as detailed and as most information as possible is very good and well-intentioned and can often be very helpful. But I don't know if we have to trip over ourselves to try to explain the difference between women and men, especially when we're sitting face to face with an individual patient for whom he or she needs just the information on what they need to do to use PrEP well enough to keep themselves safe. I think for any patient, I would counsel that PrEP's not going to kick in fully for weeks, and PrEP's not going to kick in best unless it's used as well as can be expected. And I would want to work with any patient to do as well as they could. Now, at the same time, I think we might have to be able to say, we might have to say when patients are having struggles with adherence, we may have to boost adherence in women to a higher number of pills per week than we might have to in a rectally exposed population, for MSM, for example, because of what the pharmacokinetic data are telling us. Nonetheless, I think we should be able to tell both women and men that regardless of their route of exposure, that we have really good data that if you take this in the same way that people in these clinical trials took it, which was as well as they could, then you get great protection against HIV.
Mm-hmm. Excellent. Just I have a couple more questions that I received. One is actually, well, for MSM, Truvada was tested, but what do you think about the potential use of tenofovir for MSM? And the second question would be perhaps our final question about recognizing the fact that many of the good PrEP users in demonstration studies have been, in fact, people who haven't been using condoms, for whom condom use just hasn't been working. So for them, who in fact were interested in preventing HIV infection, the use of PrEP has been a solution, and they are adhering to it, and it's showing. So, I mean, shouldn't we just more overtly recognize and advise to people who are not using condoms consistently that PrEP is an opportunity for them?
So to your second question, absolutely, and I think that's something that we as researchers and advocates and public health professionals have to get better at talking about. That PrEP is really going to have its greatest benefit for people, obviously for people who take it, but the people who may get the greatest benefit from it, and certainly may be most motivated to take it, are people who for whom other prevention strategies aren't working right now. And that really boils down, to say that in a better way, that boils down to people who aren't using condoms now, or have chosen not to use condoms now, or for whom condoms don't work right now. Mm-hmm. And how to be able to talk about that in an honest way with people in community settings, and then in individual clinical examination rooms or prescribing rooms, is going to be extraordinarily important to actually get PrEP out there and break some of the provider and public health based stigma that has limited so far the number of people taking PrEP. So absolutely, I think PrEP has its greatest benefit for people who aren't using condoms already, and our ability to talk about that has to change. For the first question, the tenofovir for MSM, is a really great and unknown question. It's not tested in the clinical trials. There is some suggestion from pharmacokinetic studies and from the rectal challenge studies that the emtricitabine, in addition to the tenofovir, may have some important additional benefit for MSM, and the current recommendation for those whose exposure is rectal is for the combination. It would be really interesting to try to explore whether tenofovir alone would potentially be beneficial, but on the other hand, I think the greater need is to put the efforts into implementation work related to. If I had controlled all the money, I would put the greater work into implementation work related to emtricitabine tenofovir rather than more research into tenofovir for MSM. For heterosexual populations, it is a real discussion point, though, that tenofovir alone has benefit for both women and men. And if costs are limiting, or if somehow side effects are limiting, it is really worth considering the tenofovir alone as an alternative for heterosexual populations, and that is raised both in the CDC guidelines and the WHO guidelines as an important alternative.
Okay, well, great. I think it's been a very interesting and comprehensive review, Jared, and we really appreciate your effort and your time this morning. I think I mean, it's really useful, and we're really thankful for your collaboration this morning. So, and also because you did this at 7 a.m. in the morning in Seattle. So thanks again for everything, and we will definitely post this cast very soon. And I mean, thanks to you. Thank you all for your participation here. Okay.